All right, so we're going to talk now about management of diabetes, and this is going to be broken up into a few different sections. First of all, who all is involved in management? Um, Pediatric patients with diabetes should be seen by a pediatric endocrinologist, in addition to their primary care provider. An adult with diabetes may be managed by their primary care, but if they have type 1 or if they have more complications, they need to be seen by an endocrinologist. A diabetes nurse educator should be available to every patient with diabetes. That is not the case. Quite a few people get very minimal education and it affects their long-term outcomes. A nutritionist or a registered dietitian can help with meal planning. An exercise physiologist can help with managing exercise and activity with diabetes. And counselors may be helpful with making the adjustment in lifestyle and dealing with a lifelong diagnosis. Most patients don't get all of those professionals. Most patients are managed by a primary and maybe an endocrinologist. If they're very lucky, they might get to see either a dietitian or a diabetes educator. So management of type 1 diabetes requires insulin. Patients with type 2 diabetes may use insulin if oral hypoglycemics and lifestyle changes are not having enough effect on maintaining blood glucose levels. Insulin is administered by injection. There have been tests to administer it by other routes, but the standard currently still is to administer by injection. Insulin need is affected by multiple factors. Emotions can affect blood glucose metabolism. Intake, what they're taking in, that would make sense, right? Activity and energy expenditure we would think about. Illness, we would think that illness takes more energy, so blood glucose levels will drop, but illness and stress actually cause the release of cortisol, which causes an increase in blood glucose levels. So patients who are sick are at risk for moving into DKA because of the increased blood glucose due to cortisol. Hormone levels can affect blood glucose levels. Children who've been very stable as far as blood sugars may have a lot of disruption when they go through puberty, and a lot of patients who menstruate report that menstruation affects their glucose levels change throughout the cycle. There are pork and human preparations. Human is preferred if tolerated. Insulin is dispensed in one concentration now for the most part. We used to have a much smaller concentration that allowed for giving smaller doses to like really young children, but the risk of mixing those up is pretty high. And so I don't know if they even produce it anymore, but if you, the insulin that we see is U100, it's 100 units per milliliter. We used to have a U40. The big thing is that you're going to measure insulin by units in an insulin syringe. So if you were to have more than one concentration of insulin, you've got to make sure that your syringes match. And that's one of the reasons that they've really stopped U40. Actually going to look up and see if they even make that anymore. So I just paused and had a look, and the only reference I see to U40 is used in veterinary medicine. And there's a reason for that. We want to eliminate the possibility of errors where possible. Insulins are classified by action time. We look at the onset, peak, and duration. In your Davis Stroke Guide, you should be able to see onset, peak, and duration for different types of insulin. You need to understand that anytime you give insulin, you need to know, when can I expect this to start working? When can I expect the peak effect? And how long should this last? For example, if I'm going to give a long-acting insulin, I might give that without much regard to when their meal is going to be delivered, right? Because as long as they are eating, and that insulin dose is based on their current intake, a long-acting insulin isn't going to peak before their breakfast gets here. But and those are often ordered at like either 9 a.m. or 9 p.m. in inpatient care, but a patient usually takes those at the same time every day. But if I'm giving a rapid acting insulin with an onset of 5 to 15 minutes, I need to make sure that that patient has a meal in front of them or has food in front of them, or quickly available to them before I give that medication. I don't want to give it when the trays aren't even on the unit. So you need to know the onset, peak, and duration. That also helps you figure out how the provider might be adjusting insulin doses, or why they might be adjusting a specific dose. An example might be the patient, if they're on NPH twice a day and their morning blood glucose is high. Let's say their evening blood glucose is high, because morning blood glucose can actually be high for a whole different reason. Evening blood glucose is high. The dose of insulin that they'll change is probably the morning NPH, because that's the one that's more likely to affect that evening blood glucose. So you need to understand rapid, short, intermediate, long acting. Patients receiving insulin traditionally got multiple daily injections of a short acting insulin, or twice daily injections of a mixed intermediate and short acting. Now we have long acting insulins, and there are patients who take insulin once a day. They may take a combination of a long acting once a day with short acting to deal with their meals. So there's a lot of different ways it can be managed to decrease the number of times people get stuck, but also to improve blood glucose control. An insulin pump is also an option. It's a subcutaneous implantable device that can stay on for 48 to 72 hours. It delivers a low basal dose with the ability to manually program a bolus before meals. So if a patient has an insulin pump, it just kind of delivers a continual dose that works a little bit more like your pancreas would. But then when you eat, you can program in a bolus, just like your pancreas would say, hey, there's more glucose, let's make more insulin. So it can be more effective at maintaining good blood glucose. However, there are some risks. It's a needle a needle has to be in place. So that means there's a risk for infection. So they need meticulous hygiene. They need to be able to safely calculate bolus doses, and they need to make sure that they're committed to properly caring for the equipment, because if the equipment malfunctions, they can be overdosed or underdosed. Insulin pumps are also more expensive. Now, I want to talk for a second about monitoring, and we come back to that later. But for glucose monitoring, we've traditionally had patients stick their finger multiple times a day for a capillary blood glucose. There also are monitors that can be put in place and left there for the same length of time typically. So they can just use a phone app to check the blood glucose on that monitor. Not only that, but it can tell them whether their blood glucose is trending up or down and how quickly. So they can combine, some patients will have both the Dexcom or something similar. Dexcom's a brand name, but it's a continuous monitor and an insulin pump, and they can use that to manage their blood glucose with less fuss. Now, we also have oral hypoglycemics. Oral hypoglycemics cannot be used for type 1 diabetes. They will not work. There are different classes of these, and you need to know the classes that are in the lecture. Okay, there are other classes. There are actually newer diabetes meds that work differently. What you're going to be tested on, because that's where your book is right now, are the ones that are in the lecture. I also strongly encourage you to continue to learn about new diabetes meds as they're produced. So first of all, there are the first oral meds for blood glucose were medications to stimulate insulin production. The pancreas is not making enough insulin, we'll make it make more. So the sulfonylureas were in, I believe they might have been the first. There's first generation and second generation. Second generation sulfonylureas actually also increase insulin sensitivity, but there's an issue with impaired liver or kidney function. So if I'm giving a medication that increases insulin production, what am I worried about? We're at risk for low blood glucose, okay? So think about that with all of these classes. There's another class, meglitinides, which also can affect liver dysfunction and has an increased risk of hypoglycemia. And there's incretin modifiers, which actually increase insulin and decrease glucagon. And they can be used as an adjunct to exercise and diet. So think about those groups of medications, okay? And you will be asked, if you're asked about a medication, I will include the class. So I want you to look at the classes. What is the class of medication? Which classes increase insulin production? There are medications that alter carbohydrate metabolism. Alpha glucosidase inhibitors inhibit the enzyme that break down complex carbohydrates into glucose. So they actually inhibit carbohydrate breakdown. So what do you think we're going to see with that? We might see some GI distress, because if those carbohydrates don't break down into glucose, then they can sit in the GI tract and ferment as they work their way through. And so these can cause some GI distress. There are medications that increase insulin sensitivity. Okay, metformin. And I told you I was doing classes, but this is kind of in its own class. Metformin decreases glycogenolysis, so it decreases the ability to break down glycogen into glucose. It decreases the amount of absorption that or amount of glucose that is absorbed from the small intestine, and it increases insulin uptake, so it makes the tissues more sensitive to insulin. So metformin has less risk of hypoglycemia because it does not actively trigger insulin production, okay? It prevents you from absorbing glucose from the intestine. It prevents you from breaking down glycogen, and it makes your tissues more sensitive to insulin, but it doesn't increase insulin production. Now, I want to look at that decreasing absorption of glucose from the small intestine. That can also lead to some GI distress because that extra glucose in the intestine pulls water in. So diarrhea is a common side effect with metformin. And for some patients, it's severe enough that they decide that they don't want to take that medication. They want to try to do something different. Thiazolidinediones, you do not have to be able to say this, you just have to recognize it. Also decrease insulin resistance. They can cause fluid retention, so we don't want to give this with a patient with heart failure. There are also medications that increase glucose excretion, and that's some of the more recent ones. They actually just cause the patient to pass more glucose into the urine, which causes polyuria. So the risk of those is dehydration. However, if they have a lot of urine in there, or glucose in their urine, and they get a wound or even say an ingrown hair in the genital region, that glucose can actually feed the infection. So there's an increased risk of infection. With some of these there's a few of the new diabetes meds that increase the risk for something called Fournier's gangrene, which is a gangrene of the genital region or area. It's very, it can be life altering. So it's something we want to be aware of. Okay, so there are also combination medications. there are different, they may combine different types of hypoglycemics. So there may be a medication that combines maybe something that decreases insulin resistance and also increases insulin production. Okay, in the next section, we're going to talk about monitoring.